Welcome back to EASD TV. Now, diabetic neuropathy is one of the major complications associated with the condition, and we've had a very interesting session which has been looking at all aspects of neuropathy, from its genetic causes to its clinical diagnosis. And I'm delighted to welcome two people who were presenting at that session to our studio. And again, excuse the noise, it's really quite noisy in here. So, first of all, Hetal Shah from the Josling Center, Diabetes Center at Harvard, and also Dinesh Selvarajah from the University of Sheffield. And you're a clinician and you're a researcher.
Yes.
So let's start with you, Dinesh. What's the problem with neuropathy that you're seeing every day?
Gosh, yeah, no, thank you very much. I mean, it's, as you said, it's a very common complication of diabetes. And I would say it's a Cinderella specialty. You know, it's a complication which is underdiagnosed, yet it has quite significant impact on the individual patients. You know, I see many patients in my neuropathy clinics or in my diabetic foot clinics who suffer the long-term consequences of neuropathy. It's the number one risk factor for amputations, and also a significant cause for painful neuropathy as well, which impacts negatively not only on the individual patient but also on their extended family.
And those ulcers are so difficult to treat, aren't they?
Yeah.
So difficult.
Yeah.
And a major consumer of both for the NHS, for the budget.
Yeah. So when you look at the costs involved with managing neuropathy, but also the consequences of neuropathy like amputations, you know, there was a study which was done about 10 years ago which estimated the cost per individual patient at about £500,000.
So about 600,000 euros.
Yeah. And you know that extending that to, you know, it's likely that the costs will increase exponentially over the intervening years. So it not only has an impact on the individual patient, but the effects on society and the overall health economy is quite significant.
But yeah, as you say, it is a Cinderella subject. I keep on saying, I'd be very willing, by the way, to have anyone on here on EASD TV who wants to talk about feet, because it is such a big issue. But why is it a Cinderella subject?
I mean, it's a good question. You know, it's something which over the years it's one of the complications which is quite difficult to diagnose. And one of the things that we've been talking about at this symposium is the need to diagnose the condition early so that we can intervene effectively when it's still, before it's too late. And the tools that we currently use to diagnose neuropathy are very crude in the sense that it doesn't pick up the disease early. And some of the things that we talked about in the presentation, you know, using some modern technologies which allow us to identify early neuropathy, potentially could allow interventions to be put in place in order to alter this natural history. And that's part of the reason why it's a Cinderella specialty, because up until recently, it hasn't been easy to diagnose. There wasn't much you can do to alter the natural history of the condition, and it can be quite frustrating to treat because the approaches that we have aren't very effective.
So you've got people coming to you at a really late stage when they've got extensive or very deep ulcers, when it's very difficult to treat, and amputation, and then once people have had amputations, they're immobile and there are all sorts of other problems. So, galloping to the rescue, Hetal, you've been looking at the genetic basis of neuropathy. Tell us a bit more about that.
Right. So, as Dinesh said, neuropathy is a very prevalent condition. It's difficult to treat, leads to complications. That said, we don't quite know what's the underlying mechanism. So that's where genetic studies have taken an interest to try to tease out what are the underlying mechanisms. But the issue is, as Dinesh mentioned again, it's the phenotyping, as we say in epidemiology, is how do we characterize or adjudicate that this is peripheral neuropathy, for example. Now that varies from study to study to study. So therefore, genetic markers, there are some that have been discovered. There are some that have been, very few that have been replicated. But that's the one main issue with the field of genetics, is that we're not able to replicate someone else's findings because the studies differ so much in terms of the definitions of neuropathy, in terms of the diagnosis, in terms of the patient populations. So that has been one issue. So
can I interrupt a second to ask Dinesh something, which is, are there people who have the same glycemic control and seem to be very similar, but one will get neuropathy and the other not?
Yeah, we see this all the time. There aren't any established predictors for neuropathy. So there's some patients who spend a lot of effort and time, managing the risk factors well, and nevertheless develop neuropathy. Conversely, you've got patients who don't pay any attention to the diabetes and seem to be protected and never get any problems with it.
Okay, so you need to both find what's driving it in terms of genetic mechanisms, but also potentially to have a gene as a marker that you might then focus your attention on this particular
Yes, you group. Can definitely give my talk, because that's exactly what I'm going to say. What I'm saying in the talk is, so genetic markers can be used for risk prediction. They can be used to tease out mechanisms. And 3, they can be used for personalized medicine. So if we do have a treatment that's effective, can it be more effective when we stratify it by a genetic marker? So those are the 3 bases of why we do genetic studies for any complication or any condition. So for risk prediction, again, genetic markers have not really quite benefited for risk prediction. Actually, it's not even been looked at much as we have looked at for cardiovascular complications or kidney complications and diabetes. So as such, there is a dearth of research. We do need more research in genetics of diabetic neuropathy.
So we love a wide open research field.
Yes, definitely a lot of gaps to be filled. Yes.
And how are you tackling this?
So up till now, the field was looking at candidate genes. So they have a hypothesis and they test a gene and see how it plays out with the risk of diabetic neuropathy. And now, as I mentioned, those studies had very small sample sizes and they weren't replicated much. Also, the ones that were, they haven't quite been any fruitful drug targets. That's not to say that these weren't good studies, but they certainly need further follow-up. From our angle, so genetic technologies changed in the last few years, and now we can genotype, the whole genome basically. So we're looking at genome-wide association studies. So we can go in and explore an individual's entire genome without any prior hypothesis. So we test millions of markers all at once. So that's been our approach to look at diabetic neuropathy, and actually we were able to conduct a large study in ACCORD and replicated the signal in Barry 2D. These are 2 large, well-known clinical trials in type 2 diabetes.
So that's very promising.
That is promising. And the genetic signal we found was also seems to have some biological plausibility. But again, this is a discovery, and now how does it get translated to the clinic? How does it needs more functional studies to tease out the underlying mechanism. So there's a lot to be done still.
So if I could give you my Vivienne Parry magic wand, Dinesh, what would you most want to help you in your clinics with neuropathy?
Yeah, no, I mean, it's a difficult question, but I think the biggest breakthrough that will, make a big difference to how we manage our patients if we can identify, individuals who are most at risk of developing the complication, and I think, if you look back at over the years and all the different studies that have been done, looking at new treatments to alter the natural history of neuropathy, they show benefits in early phase clinical trials, but when they translate, there's very poor translation to clinical practice. And that's partly because we approach, we have a one-size-fits-all approach. We assume that everybody we see with neuropathy are alike. When we know it's a more heterogeneous condition. And if we can try and, stratify patients, to try and phenotype them better, then potentially we can then target treatments which will be more effective for those individual people.
It is extraordinary that there's a huge amount of money and research gone into wound care, but actually nothing on the underlying mechanisms.
No, yeah.
Well, I wish you both luck, because this is such an important area and so consequential for patients. Thank you very much for telling us about it.
Thank you.
What an interesting session that is going to be. So it's the end of this session, but do come back to us soon. Bye for now.